Hi there, students. We are going to be talking today about the urinary system. This is chapter 6. So the outline, we're going to talk about the physiology of the urinary system, congenital hereditary disease of the urinary system, inflammatory disorders, urinary calculi, urinary tract obstruction, cysts and tumors, renal vein thrombosis, and we're going to close with the renal failure. So here's your chapter objectives and your key terms. Make sure you know what they are. This is your review of the anatomy of the urinary system, and we're going to look at the kidney here as a cross-sectional. So we have the capsule, the cortex, the minor calyces, we have major calyces, fat within there, we have the renal pelvis, the medullary pyramid, we have the medulla, the ureter, the renal papilla of the pyramid, we have the hilum coming in here, your renal sinus with your renal column and your interlobular arteries. And here is your anatomy of the bladder. You have your ureters coming in the top. You have your trigon with the openings on either side for your ureter. You have your prostatic urethra with your prostate gland and your bulbourethral gland and pelvic floor and rugae and smooth muscle with your edge of your peritoneum. So looking at the physiology of the urinary system, I'm not going to go into all of it, I'm just going to cover a couple key things. Nephron is the functional unit of the kidney. Each kidney contains more than 1 million nephrons. The idea is to filter the waste products from the blood, reabsorb water and nutrients such as glucose, amino acids from the tubular fluid, and is secreted as the form of urine. So the kidney is important for the production of red blood cells and the control of blood pressure. So with the production of red blood cells, it's important to know that if a patient is in renal failure, that they're probably anemic. Also with high blood pressure, so when patients come in with uncontrolled high blood pressure, we take a look at the kidneys and the renal arteries to see if that is the cause for the uncontrolled high blood pressure. So congenital hereditary disease of the urinary system. So we're going to look at abnormalities in size and shape, rotation, position, and fusion. The abnormalities of the renal pelvis and the ureter. We're going to look at ureter cells, and we're going to look at the posterior urethral valve, sorry. Okay, so we're talking about abnormalities of size and number. So unilateral renal agenesis is where you only have one kidney. So the ureter and half of the trigon is missing also. So on the supernumerary kidney, it's where you have a small rudimentary third kidney. It functions normal, but it's prone to infections and it can be removed. So the hypoplastic kidney appears as a miniature replica of a normal kidney with good function. So you have to rule out an atrophic kidney. So renal agenesis, you can see here on the right, we don't have a kidney. On a aortogram, it shows no right artery. So renal artery, you can see we have 2 lefts, but no right. Hypoplastic kidney, here you can see we have a kidney is a little bit bigger than normal in size, and then we have a really small kidney here, but it's functioning. So when we talk about rotation, position, and fusion, malrotation is just if the kidney is not in its normal place. So its longitudinal or horizontal axis is off. It's asymptomatic because the kidney is functioning fine. It just looks funny. So an ectopic kidney, we have a pelvic kidney where the kidney is down in the pelvis, or we have an interthoracic kidney where it's up in the chest. The kidney can be anywhere. So if you are missing a kidney when you're doing an exam, you can do a full KUB to find where that kidney's at. You also ask the patient if they have a history of kidney transplant. If they do, then the kidney is going to be in the lower right pelvis. There's a cross ectopia, so this is where it lies on the same side as a normal kidney. And most of the time it's confused. It's confused, yes. So Horseshoe kidney. It's the kidneys are on the right and the left, but the bottom poles are fused. So the kidneys are malrotated, and the lower poles are joined by a band of normal renal parenchyma or connective tissue. Ureters arise anteriorly instead of medially. And the lower poles point medially instead of laterally. The other one here is the complete fusion. It's a rare anomaly that produces a single irregular mass, has no resemblance to a renal structure. So they give these various names: a disc, cake, lump, donut, kidney. I didn't see these in the book, and I've never heard them called that, so I don't know, be brave if you want to call it that. So malrotation, as you can see on the right, the kidney looks like it's in normal position, and here it looks like the kidney is actually looking straight at us, and this is the ureter coming down. So it looks odd. It's still functioning fine. There's nothing wrong with it. It's just malrotation. Ectopic, so here they're actually, you can see the left kidney in normal position, and down here the kidney is here somewhere. It's hard to see because it's with the sacrum, but you can see the ureter coming down into the bladder. And then here's a nuclear medicine scan where they have a pelvic kidney. So the horseshoe kidney, the one in your book, I didn't like so much, so I figured I'd start with this one so you can see the normal alignment of the kidneys, and then the horseshoe kidney, you can see where it's connected around the bottom. This is an MRI T2, and you can see how the kidneys are connected here at the bottom. Kind of cool. So here's your book. Here it's showing an abnormal kidney here. I don't like the looks of that kidney. Not good. But here is your right kidney, and they're fused across the bottom. Here's your CT fused, and horseshoe kidney on ultrasound. So abnormalities of the renal pelvis and the ureter. So duplication, so a duplex kidney. Common anomaly that arises from the simple bifid pelvis to a completely double pelvis, ureter, and urovesical orifice. So complete duplication can be complicated by obstruction or reflux. Urocil, so is a cystic dilatation of the distal ureter near its insertion into the bladder. There are two types, of simple and ectopic. Simple is with adults, and the opening of the ureter is situated at or near the normal position in the bladder, but there's stenosis of the ureteral orifice, and with varying degrees of dilatation of the proximal ureter. So stenosis leads to prolapse of the distal ureter into the bladder and dilatation of the lumen of the prolapsed segment. So I haven't seen it on an adult, but I've seen this on kids a million times. So the ectopic is found almost exclusively with infants and children, commonly associated with ureteral duplication. So you need to watch and see if there's two ureters on each side. So what it looks like when there's contrast in it, in the bladder and the ureter, so a round or oval density surrounded by a thin radiolucent halo representing the wall of the prolapsed ureter and the mucosa of the bladder. So it gives this cobra head sign, and I'll show it to you exactly what the cobra head sign looks like, and you'll never forget it once you see it. So if there's not contrast in there, so it appears as a radiolucent mass in the opacified bladder in the region of the ureteral orifice. So here is your cobra head. So here's your ureter coming in, and it's prolapsed down and in, and you can see the mucosa of the bladder. So this is the cobra head sign, and you can see it here. You got the cobra head sign right there, and they say on ultrasound you can see it. I don't know. I don't see it. I have no idea what they're talking about. I figure I'd leave it so you can figure it out, but this is what I'm used to seeing, the cobra head sign right there. If you see that cobra head sign, make sure you look for a duplication in the system. So here, hard to see on here, this is a large prostate. This concerns me. I don't know what's going on there. Yep. So this right here, this is a very bad case of reflux. This is a grade 5. You can see the kidney, complete blunting of the calyces, not good. All right, posterior urethral valves. So they are thin transverse membranes within the urethra, found in males, causes bladder outlet obstruction. So it may lead to severe hydronephrosis, hydroureter, and renal damage. The valve prevents antegrade flow. It's best demonstrated on a VCUG. The proximal urethra is dilated, and the thin, lucent transverse membrane of the valve can be identified. So here you can see we're dilated, and then you can see the little membrane right there, the little valve that's causing a stricture. So here's the summary of your congenital hereditary diseases, and we're going to go into inflammatory disorders. So glomerulonephritis is a non-supportive inflammatory process involving the tufts of the capillaries that filter blood within the kidney. So it's an antibody reaction that is most commonly occurs several weeks after an upper respiratory or middle ear infection with certain strands of hemolytic streptococci. So crazy, huh? So it's more frequently, the inflammatory process is caused by chronic autoimmune disorder. It causes the glomuli to be extremely permeable, allowing albumin and red blood cells to leak into the urine, resulting in proteinuria and hematuria. It causes smaller than normal amount of urine. On chronic cases, acute cases we don't see, but chronic cases will have blunting of the calyces, and we could have increased size of the kidney. So here I don't see increased size of the kidney, but we do have blunting of the calyces on both sides. Pyelonephritis. So it's a supportive inflammation of the kidney and the renal pelvis caused by pyogenic, so pus-forming bacteria. That primarily involves the parenchyma of the kidneys. It affects the interstitial tissue between the tubules. So you can have a patchy distribution. It also affects only one kidney. If it's asymmetric, if both kidneys are involved, infection usually originates in the bladder and ascends up the ureters to involve the kidneys. So pyelonephritis is more common in women and children. It develops in patients with obstruction of the urinary tract, so it could be from an enlarged prostate also, and kidney stones, and some kind of congenital defect. It causes stagnation of urine, so that's a breeding ground for infection. It could be from instrumentation or catheterization of the ureter is also a contributing factor. So the symptoms are high fever, chills, sudden back pain that spreads over to the abdomen, painful urination, pus in the urine, and bacteria can be cultured from the urine or observed in the urine sediment. So here's chronic pyelonephritis. The acute we don't see, everything looks normal, but chronic you can see the blunting, you can see how sick these calyces are. Oh, poor patient. All right, so sorry about this. This is supposed to be an H, so I apologize. Emphysematous pyelonephritis. So that is a severe form of acute parenchymal and perirenal infection with gas-forming bacteria that occurs virtually only in diabetic patients and causes an acute necrosis of the entire kidney. So we saw this in the gallbladder also on diabetic patients. So it can do the same thing in the kidney and actually cause necrosis of the whole kidney. So next we're going to talk about tuberculosis. Yes, you can get tuberculosis all over your body, and we'll cover it as we cover the different organ systems. So renal tuberculosis usually occurs as a secondary infection from the lung, so it's spread by the blood. It can involve other sites. Yes, we'll talk about that. It manifests 5 to 10 years after the primary infection, so it may lead to the development of small granulomas scattered in the cortical portion of the kidneys. So the imaging appearance is ulcerative destructive process in the tips of the papillae with irregular and enlargement of the calyces. The example I have doesn't have the enlargement yet of the calyces. Fibrosis and stricture leads to cortical scarring and atrophy, and renal parenchyma may be replaced by massive calcification. So this can put the person in renal failure. So this is the early stage. So you can see the TB here. So it's very unique looking. It doesn't look like anything else. So that's TB in the renal parenchyma. Papillary necrosis, it's a destructive process involving a varying amount of medullary papillae and is terminal portion of the renal pyramid. So you're at risk if you're diabetic, if you have pyelonephritis, a UTI, urinary tract obstruction, sickle cell disease, or venous abuse. I'm not sure what that is. So just don't do it. All right, papillary necrosis. So here you can see on here the kidney just looks really sick and looks like half dead. So we don't have anything going on. You can see how the hilum's wiped out. This kidney still looks semi-healthy. It's starting to look like it's having problems also. So papillary necrosis, it's the death of the kidney. So not good. And you can see here on the ultrasound, we have swollen pyramids. It's too bad. Going into cystitis, inflammation of the urinary bladder, most common nosocomial infection. It's more common in women. Why? We have a shorter urethra. And the major causes spread of bacteria present in fecal material. So other causes is instrumentation or catheterization of the bladder, retrograde flow from a urine bag, so make sure you keep the bag below so it doesn't flow back into the bladder, and it also can be caused from sexual intercourse. The symptoms are urinary frequency, urgency, and burning when they urinate. The appearance on acute has no radiographic signs, where chronic cystitis has a decrease in bladder size, irregular wall of the bladder, and it has filling defects from fungus or blood clots. So looking here, this is cystitis, and we have filling defects all over. And here we have some filling defects, and we have some air in the bladder. So take a look at that. So lateral to cube, you can see the air in there. Here is your summary of findings and your inflammatory disorders. Now we're going into your urinary calculi. So urinary calculi is the most common form of the kidney form. They are asymptomatic until they lodge into the ureter and cause partial obstruction. These result in extreme pain and radiates from the area of the kidney to the groin. So it's important. It's kidney to groin, and that's pretty true indication that they have a stone. All right, so causes can be many different causes. A lot of them are hypercalcemia, so increased calcium within the body. All right, so 80% of these stones are radiopaque and detectable on plain abdomen x-rays, but 34% of those stones are missed due to the size of the location. So if it's over fecal matter or if it's over the spine. So CT is the modality of choice. We do a CT urogram. So a lot of times we have to give contrast because we can't see the stone. Ultrasound can be used for a stone, but not used for a stone smaller than 3 millimeters, as it doesn't produce an acoustic shadow. So you can see here coming down the ureter, we have dilatation of the proximal, we have a big stone right there, and then we have compression. So that little teeny white dot right there, boink, that's a kidney stone, and the little dot right there is a kidney stone in the ureter. So small. Staghorn Calculus, it's a kidney stone that fills the entire renal pelvis. It blocks the flow of urine. Stones can be removed or drains can be put in to drain the fluid so that you don't go into hydronephrosis. You can see here we've got a big kidney stone, so Staghorn right there and here, and they're putting a drain in here to drain it out. So urinary tract obstructions. So urinary tract obstructions produce atomic and functional changes that vary with regard to rapidity of onset and degree of occlusion, and distance between the kidney and obscuring lesions. So the causes for adult are calculus, pelvic tumors, urethral structures, enlargement of the prostate gland. With kids, we're looking at congenital malformations, uracil, retrocaval ureter, and posterior urethral valve. All right. So looking here at the obstruction, you can see we have an enlarged kidney here. It's delayed draining. Oh, look at this one here. We have blunting of the calyces. This is a problem. Enlarged. This one's not functioning well at all. So you can see here. So this one is completely obstructed. This one's obstructed also. You can see how dilated it is. So here's your urinary obstructions. So cysts and tumors. Looking at renal cysts, most common unfocal mass of the kidney. They're fluid-filled, usually unilocular. So septa sometimes divides cysts into chambers. We call that septated. So if it's divided into segments, we call that a septated cyst. They vary in size, may occur as single or multiple sites in one or both of the kidneys. So here is just one big renal cyst. Big one here. They talk about a beak sign and they point it out, and I don't see a beak sign, so I'm not sure. I've never heard of a beak sign in a renal cyst. I'll have to ask a radiologist because I'm not sure exactly what the beak sign is. And here's a big renal cyst. You can see the black is the fluid. All right, here's CT. So here's your kidney. This is your left kidney, and here is your cyst. This big honk right there. Polycystic kidney disease. So it's an inherent disorder in which multiple cysts of varying size cause lobulated enlargement of the kidneys and progressive renal impairment. So 1/3 of the patient also have liver cysts. It doesn't interfere with the hepatic function, whereas the polycystic kidneys can. Oh, about 10% of these or more have aneurysms of the cerebral arteries. So it's really important if a patient is diagnosed with polycystic kidney disease that we take a look at the brain of the arteries of the brain to make sure that they don't have an aneurysm, because that will rupture and be fatal. So let's see. Most tend to be asymptomatic during the first 3 decades of life, so we don't know about it, and most of the time it's found just as an incidental finding. So you can see here's a kidney, and it's just filled with cysts, Here is a kidney here, and they are filled with fluid-filled cysts. You can see all of them here in the kidney, and you can also see the liver involvement. And here is an x-ray of polycystic kidneys. So here, all these little black hypodensity areas are cysts. So renal carcinoma, also known as hyponephroma. So the most common renal neoplasm occurs predominantly in patients older than 40. Renal carcinoma originates in the tubular epithelium of the renal cortex, and the 3 things that we're looking for is hematuria, flank pain, and palpable abdominal mass. So here is a renal carcinoma on ultrasound. Here it is on CT. And here's the reformatted CT. You can see the cortex here and the top, and this is just eating away of the kidney. So Wilms tumor or nephroblastomas. So Wilms tumor is the most common abdominal neoplasm in infancy in children. It arises from the embryonic renal tissue. It may be bilateral, oh my gosh, and it tends to become very large and appear as a palpable mass. It may be differentiated from a neuroblastoma. You need to figure out which one it is. So Wilms tumor here, this big huge tumor. That's a Wilms tumor, and here's Wilms tumor on CT. So this whole thing, this right here, this little piece right there is the kidney. That's what's left of the kidney. So this is a huge tumor. All right, so here it is on MRI. This is a coronal T1. You can see the liver, and we have the tumor here, this big huge honk, and this is, I believe, the kidney, what's left of it. Okay, carcinoma of the bladder. So it originates in the epithelium. It's referred to as urethral carcinoma. It used to be transitional cell carcinoma, so that's how I remember it. Most common in men over the age of 50, is a 4th most common cancer in men. So the predisposing factors are industrial chemicals, cigarette smoking, so presumable the cigarette smoking due to the carcinogenic metabolites being excreted in the urine. So they think it concentrates in there and it irritates the lining and causes cancer. So imaging appearance. So finger-like projections into the lumen that can infiltrate the bladder wall. So on plain radiographs, it may demonstrate a punctate or coarse or linear calcifications. On urograms, bladder cancer appears as one or more papilloid defects arising from the bladder wall. There will be bladder thickening, and patients should have cystoscopy as urogram is only 60% accurate in finding the cancer. So here we have filling defect from the prostate. So it's nice and smooth and round, so we know that's prostate. So it's a boy. And then here is your bladder cancer. All right. Here's your thickened wall. So this is your bladder, and then you can see the posterior wall is thickened, and here we've got a huge mass. Not good. Here are the findings for your cysts and tumors, summary findings. Make sure you review those. So renal vein thrombosis. So it occurs more frequently in children who are severely dehydrated, so make sure your kids are all drinking tons of water. And we use an MRA to detect the abnormally strong signal from the renal veins, suggesting of stasis or no blood flow. So we look for blood flow. In adults, it's often a complication of other renal diseases such as chronic glomerulonephritis, pyelonephritis, trauma, thrombose, a lot of different reasons. It can be multiple. So acute renal thrombosis, this is what it looks like. As you can see here, this kidney is not working. It is in shutdown. So acute renal failure is what that kidney is doing. So acute renal failure is the rapid deterioration of the kidney function. It results in the accumulation of nitrogen-containing waste in the blood. It causes a characteristic urine-like odor or fishy breath is what they call it. Yeesh. There's two types. There's perirenal and postrenal. Perirenal failure causes include decreased blood flow to the kidneys, so hemorrhage, dehydration, surgical shock, cardiac failure or renal artery obstruction, and post-renal failure causes urine outflow obstructions from the kidneys, so prostatic disease or functional obstruction of the bladder neck. Other causes of acute renal failure, so kidney disease such as glomerulonephritis, bilateral acute pyelonephritis, and malignant hypertension, nephrotoxic agents, so like antibiotics, contrast material, heavy metals, intravascular hemolysis, and large amounts of myoglobin, so muscle protein in the circulation from muscle trauma or ischemia. So one of my friends worked out really hard, his legs, and actually had this where he was going into renal failure because there was so much muscle protein in his blood. It's interesting. All right, he's fine. All right, so here, this is an IVU, so an IVP basically, and we inject contrast, and as you can see, after 20 minutes, these kidneys are just blushed. They're what we call blushed. They're not functioning. It's blushing of the kidneys, just means that they have contrast in them, but they're not able to do anything with the contrast, so no calyce filling. Chronic renal failure may reflect perirenal, postrenal, or intrinsic kidney disease. Causes of chronic renal failure: bilateral renal artery stenosis, bilateral ureteral obstruction, intrinsic renal disorders such as chronic glomerulonephritis, pyelonephritis, and familial cystic disease. So here's an ultrasound of a kidney in failure. You can see how small it is. And here are your summary of renal disorders. And that sums up your urinary lecture.